Hi, hello. My name is Ricardo. My partners are Shi Yu and Desiree. And today we're going to be talking to you guys about Parkinson's disease.
Parkinson's disease is a chronic and progressive neurodegenerative disorder that primarily affects movements and is characterized by the gradual loss of dopamine-producing neurons in specific regions of the brain, particularly the substantia nigra pars compacta in the basal ganglia. The loss of dopamine-producing neurons leads to disruptions in the brain's ability to control muscle movements and coordination.
Parkinson's disease is a complex disorder that can manifest with various different subtypes, each characterized by different clinical features and disease progression. Here's the different subtypes. First one is tremor dominant Parkinson's disease, and this one has prominent tremors as primary motor symptom, less pronounced bradykinesia and rigidity, and the progression tends to be slower. Next, we have postural instability and gait difficulty subtype. There's challenges in imbalance, walking, and coordination, less emphasis on tremors and rigidity, and freezing of gait may occur. Next, we have young onset Parkinson's disease. This is diagnosed in people under the age of 50 with different symptoms, profiles, and progression rates, and may have genetic factors. Next, we have drug-induced Parkinsonism, with symptoms resembling Parkinson's due to certain medications. Symptoms often resolve after stopping the causative medication, and they have similar motor symptoms as typical Parkinson's. Next, we have atypical Parkinsonian disorders, and these present with Parkinsonian symptoms but differ in pathology and progression. They may have additional neurological features beyond Parkinson's. These syndromes are typically more aggressive in progression and may not respond as well to standard Parkinson's disease medications. Some common disorders include multiple system atrophy, progressive supranuclear palsy, corticobasal syndrome, Lewy body dementia, and vascular Parkinsonism.
In Parkinson's disease, there is a gradual breakdown or loss of neurons. Many symptoms of Parkinson's arise from the decline of neurons that produce dopamine. When dopamine levels drop, it disrupts normal brain activity, leading to movement issues and other symptoms of Parkinson's disease that will be discussed a little later. The exact cause of Parkinson's remains unclear, but there are many factors that contribute, which is something else that we will be discussing later. Now we're going to talk about causes of Parkinson's disease. The first one is genetics. While specific genetic changes can cause Parkinson's disease, they're rare except in familial cases. However, certain gene variations slightly increase the risk of Parkinson's disease, though the overall risk remains relatively low. The second factor is environmental factors. Exposure to certain toxins or environmental elements may slightly elevate the risk of developing Parkinson's later in life, though the risk is generally small.
Here are some statistics related to Parkinson's disease. Approximately 1 million people in the US and over 10 million people worldwide are living with Parkinson's disease. In fact, Parkinson's disease affects approximately 1% of the population over the age of 60, making it the second most common neurodegenerative disorder after Alzheimer's. Up to 15% of individuals with Parkinson's disease have a family history of the condition. The average age of onset is around 57 years old, and the majority of the cases are diagnosed in individuals over the age of 60. Furthermore, men are approximately 1.5 times more likely to develop Parkinson's disease than women.
Now we're going to talk about risk factors for developing Parkinson's disease. The first one is age. Parkinson's disease typically occurs in middle or late life, with the risk rising as individuals get older. Onset usually happens around 60 years old or later, though it's rare in young adults. Genetic counseling may be beneficial for those who are young with Parkinson's disease because their family planning decisions is important because their experience with certain social situations and medication side effects may be different from older individuals with the disease. The second one is heredity. Having a family member with Parkinson's disease can elevate your risk for developing it, particularly if you have multiple relatives affected by the disease. However, The overall risk remains relatively low unless there's a significant family history of Parkinson's disease. The third one is sex. Men have a higher likelihood of developing Parkinson's disease in comparison to women. The fourth one is exposure to toxins. Continuous exposure to herbicides and pesticides may slightly increase one's risk of developing Parkinson's disease.
Parkinson's disease presents with various clinical presentations affecting both movement and communication. These include tremors or involuntary shaking, bradykinesia or slowed movement, muscle rigidity or stiffness, postural instability or balance issues, speech changes such as soft voice or slurring, facial masking or reduced expression, dystonia or twisting movements, and dysphagia or difficulty swallowing. Dysphagia in particular is a significant concern as it can lead to aspiration pneumonia and is a major cause of death in Parkinson's patients.
Today I'm going to talk about relevant history and assessment information to obtain. This is Gail Brown. Is a 68 years old female. She is a retired farmer who lives at home along with her dog. Miss Brown's husband passed away 5 years ago. She experienced a minor fall after tripping over her dog and landed on an outstretched right hand, leading to wrist pain. She saw her family doctor regarding on her wrist, but also complained about some recent trouble with balance and small hand tremor. She was referred to a neurologist and diagnosed with earlier stage idiopathic Parkinson's disease. Now her doctor referred her to a speech language pathologist for an evaluation. Here's Miss Brown's medical chart. There's a few things we have to take note. She is a 68 years old female diagnosed with idiopathic Parkinson's disease, and she has right wrist injuries resolved that happened 3 months ago, and she has a history of depressions. And we see a list of medications she's currently taking. Prior to the onset Parkinson's symptoms, she's able to walk about 200 meters to her friend's house, gardening, and performing daily activities independently. And right now, she feeling less confident with her reaction time, less confident walking outside, no issue with stretching and bathing, no problem with stairs, no problem with bed mobility. Brown's assessment information for her oral MAC exam. For her face is unsmiling, masked, expressionless at rest, jaws are within functional limits, lips appear tight and rest during movement, and her tongue strength are relatively normal, and other observations include reduced chest and abdominal movement during quiet breathing, infrequent swallow leading to excessive saliva accumulation or drooling. Is Miss Brown's assessment information for her motor speech. The findings are during the assessment, the patient exhibit the following behavior: reduced loudness, harsh vocal quality, breathiness, low pitch, repeated foamings, rapid and blur AMR rate, imprecise consonants and prosthetic abnormality, such as reduced stress and short rush of speech. And then that diagnosis based on assessment finding, the patient has diagnosed with hyperkinetic dysarthria secondary to Parkinson's disease. Brown's treatment considerations. We can do voice therapy. Exercise may include respiratory training, speech exercise. We can do articulation and increase her intelligibility. Techniques may involve exaggeration of speech sounds, practicing specific speech patterns. We can do fluency and rate of speech, pacing exercise, rhythmic speech drills, and we can do communication strategies. And this may include techniques using gesture, facial expressions, and nonverbal cues to enhance communication. We can also integrate technology into her treatment, such as speech generating devices or communication app. And lastly, we could do swallowing therapy, exercise to improve oral muscle strength, swallowing coordinations, and reduce risk of aspiration.
SLPs play a crucial role within multidisciplinary teams. Initially, they conduct comprehensive assessments of patient speech, language, voice, among other areas, utilizing standardized tools, clinical observations, and interviews to identify communication deficits and assess severity and progression of disorders. Following assessment, they design individualized treatment plans focusing on improving speech intelligibility, clarity, and overall communication effectiveness. Techniques may include respiratory training, articulation drills, phonatory exercises, and prosodic training. Collaboration is key as we work with neurologists, physical therapists, OTs, and social workers to ensure coordinated care. This involves sharing assessment findings, coordinating treatment goals, and providing regular updates on patient progress. Referrals to specialists may be made necessary when, such as to movement disorders, OTs, or voice therapists. And last, education and support are also provided to patients and their families, including strategies for participation in therapy activities and access to resources and support groups. Ethical considerations. First, informed consent, which is where we ensure that the patient and the patient's family or caregivers fully understand the nature of the assessment and procedures, including risks, benefits, and alternatives. We also recognize the patient's autonomy in choosing the type of intervention they wish to pursue, while also providing guidance and support based on clinical expertise. Then we have cultural sensitivity, which is where we recognize and respect the patient's cultural background, beliefs, values. And last, we have scope of practice. As SLPs, we recognize the limitations of our practice and refer patients to other healthcare professionals or specialists when appropriate. And here are our references for our presentation. Thank you so much for your time. Bye bye.